Good morning, everyone. I would like to thank WOC for the opportunity to present our ideas about conservative management of fractures. We all know that fractures can be treated using many different ways, broadly conservative or surgical. Recently, there has been a remarkable change in the treatment of fractures and dislocations from non-operative to operative thanks to advances in anesthesia, improvements in sterile techniques, and advances in technology of internal fixation. The availability of these facilities is, however, not universally guaranteed. In the year 2009, in my hospital in Nairobi, Kenyatta National Hospital, which is the main teaching and referral hospitals, the patients who were seen in the accident and emergency requiring orthopedic attention were as shown there. Of all these patients, only 3% were admitted, which means that 97% had to be managed using skills that are non-operative. And the reality of the situation is that even those who were admitted, only 50% were operated, and many of these were fractures rather than orthopedics. What this therefore means is that we have a lot of crowding in our wards. We have, for example, the adult wards in our hospital, which is a 2,000-bed hospital. We have only 32 times 3 beds, and most of the time these beds have an average of 100 patients and more. Therefore, there are problems with nursing, and at times even during a ward round, you may not have an opportunity to be able to go around the patients. And again, as I have said, most of our trauma patients require some sort of surgery. But because of the reality of the availability of surgery, these patients have to stay very long days in the hospital waiting for surgery. In one study, the hospital stay ranged from 1 to 93 days with a mean of 20 days. Generally speaking, again, is that most of our patients have to pay for themselves. 73% of the patients have to pay themselves. We do not have a social security system to take care of the patients, and less than 1% of them have a medical insurance coverage. And in fact, even this 1%, quite a portion of them are in the exclusion criteria. Most of these patients have to travel long distances seeking attention, and when you look at conservative versus operative treatment may look cheaper, but operative treatment requires one large sum payment at a go, unlike a non-operative treatment. And in fact, for the patient, it is more expensive to do non-operative treatment to the society, but to the patient himself, it is much cheaper for him because he does not have to shoulder the cost. If you insist that you have to do surgery, the kind of situations we see in Nairobi is this. You have patients who have had operations, and you see this kind of outcomes. In the X-ray on your left, there is a circulage wire which obviously showed that the person who was doing this operation, this must have been an open operation, and could not realize that there is the nail has not gone beyond. In the second one, it is obvious that there was a limitation of facilities. There was no way an intraoperative X-ray was checked in this kind of a situation. So these are the kind of problems we meet day in, out, referrals to our institution from operative treatment. These are the things we have to use plaster of Paris, as the first speaker showed, and when you are, or we may resort to traction, either skin or skeletal traction. Commonly, the Parkins and modified Russell's traction. These are some of the things we require when we are doing Parkins traction, and those are the indications of Parkins tractions. These forms of treatment, also conservative forms of treatments, have indications and contraindications. And that's why we believe that for people who are trained in our circumstances, they have to be properly trained in conservative means of treatment, so that to be able to pick these patients very well. After all, most of the patients that are going to be treated are by an operative means. This is what you do with PAC instruction. And generally speaking, when you look at PAC instruction, one advantage is that these patients are exercising, and that exercise, obviously, when you have one physiotherapist for 100 patients, if the patient is going to do this on his own, then obviously you have reduced the need of physiotherapists. This is the kind of results that you may see, that you've gotten callus formation, and this may lead to union. But again, this actually shows that when you are treating this, the person who is treating this has to be properly educated to know what is acceptable and what is not acceptable. I mentioned this about the Parkins traction. The guidelines to succeed, as I've said again, is that personal one has to follow up what is going on to be able to get good results. In children, we also say that remodeling really most of the time takes place. Even it looks very bad, there's remodeling usually occurs. But now we are under a lot of pressure for parents who want their children to be treated. And more important also, it is important to appreciate is that not every problem in children will correct, particularly if you have rotations and valgus angulations, they may not be corrected. That therefore means also that for anyone who is going to apply conservative means of treatment, you must have very good skills to be able to pick up this. Again, if you are doing conservative means of management, it does not mean that you are doing neglected means of management. Because if you look at these two slides, like the first one, that is a patient in a plaster of Paris who is purportedly under conservative management. And obviously there hasn't been no reduction in that fracture. When you look at the one on the right side also, there are all sorts of things like a Thomas splint being used inappropriately and all that kind of thing. So that even when the circumstances are deficient, you need people to be properly to understand that, to properly understand how to apply conservative means of transport. This is a patient I saw just before I came here. This patient was seen in 1970, more than 40 years ago. And the patient tells me that he had some sort of operation. Now he's 75 years old. The granddaughter has money now, and now she brings the grandfather and say, now something has to be done about my grandfather. So this is one example of whether there was conservative or operative treatment, it was definitely not done well. And these are the kind of problems, if you have to do operative treatment in my setup, you will meet on a day-to-day basis. So we have said again that we lack well-trained surgeons and other healthcare providers. Even with our calendar introduced postgraduate training in orthopedics, we obviously are not going to be able to train our people very well. And we have we lack appropriate and affordable equipment and implants and of reliable, clean surgical environments, so that the risk of surgical complications of orthopedics procedures, just as we were told by the first presenter, is unacceptable levels. So conservative management remains a viable portion for most of our fractures. And it is important to appreciate that our patients also, quite a number of them have a problem submitting themselves to surgery. Traditionally, they do not want surgery. And again, if you add the fact that they have to pay for the surgery, then that is a negative incentive towards them accessing surgery. And the patients have to travel long distances. In a country of about 40 million, we have only 40 orthopedic surgeons, most of whom are in Nairobi, the capital city. Thank you.